Good morning, everyone. Welcome back to the 20th edition of Treat Live. Today's a very exciting day for us. This is our first live session from our Mount Sinai West outpatient hospital. So I wanted to thank Siemens for helping us with that setup and BroadMed AV for our continued partnership with our AV equipment here. So my name is Aaron Fishman. I'm the co-director of the Treat Live Symposium. To my right is Kavi from University of Alabama in Birmingham. He's our guest moderator today, but he actually flew up here specifically to help moderate this case. We also have another guest moderator, Leigh Casadaban from University of Colorado. And then in our room today, we have Dr. Dan Shilo and J. Vairamurthy, who are going to present a very interesting case here today of a knee embolization in a patient with chronic knee pain. So without further ado, I'm going to turn the room over to Dan, and he's going to introduce the team over there.
Thank you so much. So I just want to emphasize, this is the inaugural case over here, the first ever live treat case from Mount Sinai West Room 5, our Siemens room over here. I want to thank everybody that made that a possibility. A lot of people behind the scenes worked really diligently to make that happen. Obviously, thanks to Siemens for the grant to make this educational content possible. Everybody in the room here, our anesthesia staff, our technical staff, our nursing staff, there's a lot that we can do over here. And, we're going to be obviously uploading this. We have the chat box. So, we can really make this a whole series as we do cases from this site moving forward. If you guys want to see like a musculoskeletal embolization series, we've already done a radial GAE. We're doing antegrade today. We can do up and over, pedal. We can talk about equipment selection. We can talk about different embolics. So if that's what you guys want to see, definitely let us know and we can accommodate it. And Aaron, you didn't mention, actually, this is the 20th treat live case that we've done, which is a testament to Aaron's blood, sweat, and tears to putting this together. Without further ado, I'm going to introduce the people with me that you already did. The real Dr. J. Vairamurthy here to my right, and one of our fantastic fellows, Tara Bahramipour.
Good morning, everyone. So we'll be presenting a case of genicular artery embolization for left knee osteoarthritis. So the patient's a 73-year-old woman, has a past medical history of tachycardia, status post-ablation, December of 2023, OSA on CPAP, hypertension, hyperlipidemia, type 2 diabetes. She is status post-right total hip arthroplasty in July of 2023 and has the left knee osteoarthritis. So patient states that she has knee pain that is constantly present and worse with activity that interferes with her daily activities. On the visual analog scale, she scores her pain on the left knee 7 out of 10. And then knee injury and osteoarthritis outcome scores for the left knee is 53%. She has tried physical therapy, NSAIDs, intra-articular steroid joint injections, PRP, with limited and temporary relief of that left knee pain. So in terms of her physical exam, she does have tenderness of palpation over the left intermedial knee. Otherwise, the exam is unremarkable. Her labs are also within normal limits. Pre-procedural X-ray, grade 3 left knee osteoarthritis based on the Tellinger-Lawrence classification. In the images, you can see there mild degenerative narrowing at the medial joint space with the marginal osteophytes. And then there is subchondral cystic changes with irregularity of the articular surface of the left patella. MRI was done pre-procedurally. She has high-grade cartilage loss at the medial ridge of the patella, extending to the medial patellar facet with reactive marrow edema. She's got that moderate-sized popliteal cyst. She has mild intrasubstance degeneration of the body of the lateral meniscus. And then she's got area of focal cartilage loss in the weight-bearing portion of the lateral tibial plateau. For assessment and plan, so she's a 73-year-old woman with past medical history of atrial tachycardia, status post-ablation, OSA, hypertension, hyperlipidemia, status post-right total hip arthroplasty, and left knee arthritis. The left knee pain interferes with her daily activities and is progressing. It has been refractory to conservative management and conventional minimally invasive procedures, and she's declining surgical intervention at this time. So our plan today is left genicular artery embolization via ipsilateral antegrade femoral artery access.
Fantastic. To my mind, this is a KL3, pretty standard patient that would have pain, has failed all the therapies that Tara mentioned, is not looking for a surgical intervention, wants to avoid it at this time. For any of you guys, and again, thanks to Leigh and Kavi for joining us. Anything that jumps out at you guys about the presentation? I hope you went through the entire MRI as it scrolled through.
Got a lot of pain, but structurally the knee looks really good on MRI. So I think this is a perfect patient for this case.
Awesome. Yeah, I mean, we should definitely talk about later on about how we're doing patient selection and, the severity that we're willing to do. Let's put up on our screen our overlay, and we can kind of show you where we are so far. So the way that we're doing these, and again, this goes to like the educational content that we can do going forward. We've done these radial, we've done these antegrade, we've done these up and over, we've done these pedal. We had a day where we had all sorts of accesses and different embolics. Our setup today is an antegrade SFA access. We have a radial. If we can look at the groin over here, we have a radial prelude for French. We have a 4 French angle glide. We have two Asahi angle microcatheters that we're going to show today. I'm going to hold up the tip here, Phil, if you want to bring it over. We have a 1.7 and a 1.9. We have the Tellus and the Volute. I'm holding it up. Let's see if you can focus on it.
So Dan, which one is the 1.9? Is that there's a Volute and a Tellus? Which one is which?
Yeah, there's a Volute and a Tellus, and they're 1.7 and 1.9. Yeah, the Volute is
Tellus is 1.9.
Yeah.
Volute is 1.7.
Okay, and what wire are you guys going to put through that, Dan?
So we have a Fathom, we have a Meister on the table right here, and we're going to kind of show how we're doing it. Jay's done a spectacular job of catheterizing what we already have. One other thing that we did off screen is we did the spin that we do. We've developed a protocol with Siemens. It's a multi-spin sequence where we do an injection through the SFA. After our DSA, we time it in order to see the vessel space on that initial DSA. We're doing one spin, which is a non-con, comes back to position, reorients to the initial spin, does another spin with contrast, does an automatic subtraction, and gives us what you're seeing hopefully on the screen right now. We then have the ability to mark all the vasculature, the areas of interest, and then we can kind of track that. This helps us, number one, obviously there's some variant anatomy in this, so it helps us get that extra 5-10%. Obviously, the majority of these vessels, if you're doing a DSA, you'll see them at first blush, but this kind of lets us be a little bit more specific. And obviously, going forward, if we want to do some retrospective work with it, it really helps us review all of that. So that's basically where we are now. Jay did a fantastic job of catheterizing our first vessel. We're going to do a little puff, a little DSA, and then we're going to talk about how, where, and when we want to embolize this initial vessel. So
would you guys be able to show us the angiogram, just the initial angiogram of the SFA before you guys start puffing that vessel, just so we can orient what you've done so far? Because I can see the overlay, but I don't see the actual 3D yet.
Okay. You can see the SFA here?
Yep.
Yeah.
Okay. Because we have multiple screens. I'm not sure which you can see. So yeah, it's really nice here. We can see a big DGA that we're in at the moment. I think that's really where the money here is going to be. You can see the BB markers on the subtraction. You can see one kind of a little bit north of the patella and then one on the medial side there. Are you guys able to see that?
Yeah, we can see the BBs. Yep.
So we always pre-procedurally mark that. And if you look at that DGA in the blush there, I think we're seeing something pretty clear that's going to be a target to go after. And then we have other vessels. Some of them actually are a little bit less faint. This isn't, I don't think, a standard, anatomy, superior medial, superior lateral with the classic going appearance, but there's some great targets to go after here, I think.
Yep.
It brings up a great point, Dan. I mean, I think a lot of people in the community at large will just use the DSA to plan their intervention. I think going after each individual vessel, even though you don't see a blush on the parent DSA or the non-selective shot, is actually, I think, very relevant. And the cone beam actually helps do that. Leigh, what do you think?
A little bit of both. I always do the cone beam. I think the cone beam is really important to help map out the arteries. Yeah. And sometimes if you don't see a lot of blush when you're injecting from the SFA, you can always get into it. And sometimes you'll be surprised you see a lot more blush than you didn't see initially.
Yeah, I mean, this is a beautiful blush here. So the interesting thing here is we don't really have, as you saw in the SFA, that classic, what I was just saying about the superior medial. And what we do have here is kind of an earlier bifurcation here going into both vessels. So for you guys, would you go individually into one of these? Would you embolize from here? In this case, I'm somewhat tempted to embo from here.
There's another branch that's sort of flashing right at the top there.
Yeah. We definitely have a cutaneous branch there,
Yeah, I don't know exactly where that's going yet. I mean, I have to go back and review the initial run or maybe even the cone beam just to see. Do you guys have any sense of where that branch, not the two linear ones going south from where your catheter is, but the one that's sort of off to the left on our screen? We can see it, but where do you think that's going? I just don't know if I know yet. Do you know?
I always go back and look at the cone beam, and that to me is the value of the cone beam, just to get a sense of where everything is going and not have to guess personally. But
let me help you out here as I puff down with my my Tellus here.
Yeah, that's an amazing catheter that I mean, a lot of these small microcatheters allow you to just navigate without a wire. Is that of an angled tip, Dan, or is it just a straight tip?
It does. It does. It's something we've talked about. They are shapeable. Yeah, this thing will just go wherever you want it to go, and I can just direct it how I want, and I can go really deep. See, this would be the Casadaban technique, is my understanding, right?
Yeah,
As
I like
we were
to go
talking
distal.
about going more distal. So would you go more distal than this, or would you park it right here?
I think right there is perfect.
Right here is go. Cubby, what about you? How do you feel about this? Because I'll be honest, this is usually a little bit more distal than I would do.
I completely agree with Leigh. And actually, I love your point on the angle tip micros. I generally start with angle tip micros, and a lot of people think that there's really no torqueability. You do have a little bit of torqueability. You can really puff your catheter out very easily and not always have to manipulate it with a wire. So it's a great technique.
Do you find that you get more torque when you come antegrade than up and over?
I do.
Yeah.
Yeah, for sure.
So I think if you're facing a challenging case where you think you might lose some torqueability, I think an antegrade approach is great. What do you think about this angiogram, Leigh? Would you give nitro here? Is that something that you typically do, or would you?
I always give nitro.
Yeah.
I mean, that looks really good as it is, but I would give some nitro anyway.
This looks great. So I give nitro every single vessel, almost every single vessel that I do. So I'm going to give 200 mics of nitro right now.
Getting distal there is you're past that branch, which I'm going to guess is probably a cutaneous branch. It looked like a really big, maybe, sub-Q or cutaneous branch that you're now past, and you're preserving that one. So I think you're going to limit your adverse events by getting distal.
So at this point, you'll probably treat this vessel, then go back up, and then go back into that other vessel more medial. Is that your plan, Dan?
Yeah, so I would definitely treat this one. I'm definitely going to investigate the other one because I think there is, definitely a benefit to doing that. So we'll do a post nitro run. Let's see how this goes. I'll be interested to see. We sometimes get some reversals. Wow, look at that.
Wow.
The blush, the blush is significantly different. I mean, we could put the runs up side by side, but it's probably hard to do live. You go back and you look, it's a clear difference post nitro for sure.
100%. I mean, and I think this is a testament to the going a little bit more distal and giving the nitro and investigating in such a way that you're really going to make sure you're getting all of the value that you can for the patient. Because I think there's an easy way to do this, but in order to really get that last bit of efficacy and do it the right way, I think it requires a few of these extra steps.
Dan, you said something about flow reversal. Did I hear you correct? You want to expound on that? Because I've seen the same. I'm curious what your thoughts are.
Definitely. So, when we're giving nitro, actually, let's shove this for just a second because I want to talk about the embolic. So right now I'm going to do aliquots. When you guys are doing permanent embolics, what are you guys doing? What would you do here for an aliquot? Are you just pumping in particles? Are you doing small aliquots? How are you guys doing this? I'm going to do a 0.3 aliquot and then push that in. How do you guys feel about that?
What are you using?
That's exactly what I would do.
So we have 200 hydropearls here.
200 hydropearl.
Nice.
Okay. So I'll confess that I've gone the resorbable route at this point. So I'm really not using aliquots at this moment, but yeah, it's a great point if you're using permanent particles.
So that's really interesting, and we've really only done permanent particles here at Mount Sinai. Can you just tell us a little bit about your technique in terms of? I mean, there's obviously lots of resorbables that are in trial and everything else, and we can talk about that in a second. But what's the difference in your technique whether you use resorbables versus permanent? How would you do it differently?
I am less worried about reflux and non-target embolization. I think that's kind of the largest aspect of it. And so
how would you describe your endpoint, permanent versus temporary?
I don't know that I'm going to full stasis, but I'm definitely more aggressive. I think just pruning with a permanent embolic is very appropriate, but if you have a true resorbable embolic, going to true substasis or near stasis is relevant in this day and age. I don't know that I have data to support that's the right thing to do, but we're doing it successfully without adverse events at this point. Leigh, how do you feel?
Yeah, right now we're still using permanents. We're using 100 micron permanent embosine. I think resorbables are great, and they're definitely the future. And I'm excited to see what these new clinical trials are going to show.
Leigh, your decision to use 100 versus something like 200 or 250, what's the basis for that, just so the audience can understand?
Great question. I think with 100s versus 250, I think 100s you're going to probably get a little bit more adverse. You're going to see a little bit more skin color changes on the skin, but I think you might get a better outcome. I do believe that smaller beads, you can plug up the tiny little capillaries a little bit better, and I think outcomes are probably going to be better. But do I know that for sure? No. I think we need more data to really determine that. My thought is that smaller particles are going to get you better outcomes.
Yeah, I mean, I think that's the balance. Yeah, I don't think I think universally, no one's going smaller than 100. I think we're pretty well established on that. I had some issues with 75, so I think 100s, 200 hydropearls, 100 to 300 embolics. I think that's really overwhelmingly when in permanent embolics what people are using nowadays.
So Leigh, when you do the 100 Embozine, like you mentioned, you're probably seeing some skin changes in a fair amount of patients. So what do you tell them when they get them? I mean, what do you tell them beforehand when you see them, and then also, what do you tell them after when they tell you that they have these skin changes?
Yeah, absolutely. You always want to warn the patient ahead of time. And I would assume, to expect a little bit of skin color changes. I think a little bit is normal. Most patients have no problem with that. But I also found that by using ice packs, if you leave them on a long time, you might get no skin color changes at all. So I leave the ice packs on for at least 5 minutes, and that's really helped with my adverse events.
Even with resorbables, I'm still using ice packs, which may be totally counterintuitive, but I tend to just, as soon as I get the cone beam, the ice packs tend to go on for me. But I don't know how you guys are all doing it.
Yeah, we definitely have the ice pack on. We leave it on kind of going in recovery, going into the room. Usually at the time of embolic, I'm taking it off because I don't want to leave the ice pack on for too long. But so it's not on at the moment, but we definitely use the ice pack. I subjectively feel like that makes the angios ever so slightly better with the cutaneous, but I have obviously no evidence, and it could just be me making myself feel better. So we did a run after the embolic. Clearly, a lot of the medial aspect of the blush that we saw before is gone. By the way, the other thing that I do, kind of subjectively, I always pull back a little bit. Like, I don't want to be too distal and blast things into the vessel. You can see I pulled back a little bit from where I was actually embolizing. Leigh, do you do that at all, or you stay distal when you're doing your final injections?
It really depends how the flow is. If you're not getting good flow, definitely pull back a little bit.
Yeah, it's
how much did you inject so far, Dan?
This was the initial aliquot. This is the 0.3. I washed it out. I did the DSA. How do you guys feel about this?
Looks great. It's beautiful. The vessel's still open, but all those little channels are all pruned. I really like that.
But again, ice packs,
Cubby and I are heavy embolizers, apparently, so we would probably do a little more.
I'm going to as well. We clearly have, the majority of the blush is gone. We have a lot of these like small perforated sore the condyle, and I want to get some of those. It's a little bit more blush, so I'm going to give another 0.2 aliquot here.
I think Leigh's earlier point is great, though. I think if you're using a smaller particle, maybe you don't need to add a little bit more. But if you're using a larger particle, maybe it's wise to be a little bit more aggressive. That's not a data-driven statement, but I don't know. It's the way where my head is at the moment. I don't know how you all feel.
No, I think that would be 100% right. I mean, a lot of a lot of us that are doing a number of these, we're basically biased by the experiences that we've had and the issues that we've had, and so I think that's really definitely a valid point. I've definitely done 100 Embozine in the past, but predominantly it's been the 200 hydropearls and the 100s to 300s, as those have gotten much more difficult to obtain. And kind of how we're doing it here, going a little bit more distal, kind of being at the condyle here. Sometimes if you have the classic more gull wing appearance, I'll be even more proximal as I'm coming up and over, and I'll just park it at kind of the apex of that. But in this case, I think we're getting a great embo by going a little bit more distal.
Here's a question for Cubby and Leigh. Do you guys feel the amount of vascularity you see on the angio correlates in some way with the patients that respond, the patients that don't respond? Because right now we're sort of still trying to understand who the best candidates are for knee embolization. Is that something that you guys have seen in your practices?
I haven't. I'll be honest. It's really hard to predict who's going to respond and who's not. I haven't really figured that out myself.
Also goes to pre-procedure MRI. We didn't really talk about this yet, but obviously you guys got a pre-MR. I tend to get an MR with contrast in particular. I don't know a lot of people that are actively looking at synovitis scoring and things like that beforehand. I know it's kind of built into some of the trials that are coming, so I think we'll know more very soon. But I love the idea of getting a preoperative MR. I don't tend to rely on the X-ray alone. We know that the KL score is very subjective and can depend on the what position the patient's knee is in, right? So I don't know what y'all are doing. Are you guys getting contrast ever?
For the most part, we're getting non-con. It's what we can get approved, to be perfectly honest with you.
Sure.
And to be honest, I'm going to ask you the tough question, and hopefully, Leigh, you can jump in on this too. But so I'll answer it myself first. What are you guys really using the MRI to do? If you can really give people that are, people that are starting off to this, what are the pearls? I think the greatest utility, to be perfectly honest, for me is going to be number one, is there something here I don't want to be embolizing? Is there an insufficiency fracture? The number one thing I'm using it for is not, was it mild or was it moderate or was it moderate, was it severe? I don't think that's the great utility. It's number one, that. And then number two, there is this sense of, the mechanical versus the inflammatory joint, which is a very vague concept, of course, but to give it extremes as an example, somebody who has, it's mechanical, it's clicking, it hurts every time I click, they have a bucket handle tear versus the person who has loss of synovitis, a lot of swelling, has that nighttime throbbing pain. These are obviously huge generalizations, but it gives me a better feel for that type of a patient in terms of the mechanical versus inflammatory. And so I'll let you guys answer that question too, because I know it's a tough one. So I took it first. All right. I think it looks great. I think we have the first and second order.
No, I think it's great. You definitely want that parent vessel open. It looks good.
Yep.
So if I was flushed here, it looks like you're flushed. I was going to say just pull back and then maybe, I don't know if you can navigate this without the wire. Maybe you can sort of torque it into that branch. That would be really cool. If not, I'm sure the wire will go really easily. That's a tough little angle, though, I think.
It's a tough angle for sure, yeah. I think as we get, bigger angles, like more C2 swan neck kind of on these types of catheters, I think it's really going to help us out. But yeah, definitely I think we should investigate this guy over here because, again, she doesn't really have a classic SMGA. And so we really want to get our money's worth for, let's say, that BB marker. And we're gonna publish this, but we are seeing correlation in lateralities with these types of embolic sizes, and we're going to try to score the vascular blush too. But just by embolic volume with the permanent embolics that we've done so far in our cases, we are seeing a correlation with laterality. I do want to come back also. So, Covey, you'd asked me about the flow reversal. Definitely, I've had cases where I'm injecting, I'm a little bit more distal in a vessel, and I'll give the nitro. And, it's kind of well established that these are, anastomosing vessels, and definitely post nitro, I'm getting a reversal of flow. So I'm going to ask you what you do in those cases, and just because it's tough, I'll tell you. In my case, what I generally do is I've found in those vessels I can go a little bit more distal, and kind of get it to puff back into where I want it to go. Beautiful.
Size catheter. Is this the 1.9 or the 1.7? Remind me.
I think this is 1.9, right?
So this is the 1.9 actually.
Yeah.
Wow.
I think both sizes are great. Merit also has a 1.7 Pursue. I've used that as well. I know a lot of people use two French True Selects. I tend to be in that 1.7 range today. Leigh, what are you using?
Yeah, definitely 1.7. I like to get real distal, and I think a 1.7 is necessary for that.
We're all in agreement here that 2 is probably the largest size we would use for these cases, and
good.
2.4 as an example, a standard 2.4 microcatheter that we're using for liver embolization is probably not ideal for this. Would you agree?
I 100% agree. I will also say, we're in an era where all my liver directed therapies are like sub selective. So I tend to start with the 2 French in the liver as well. That's me personally. But.
So what are you using a 2.4 now for?
Literally the only time I'm using a 2.4 is if I need to drop a pushable coil. That is the only time. So it's very rare for me in my practice. But yeah.
So how do you guys feel about this run?
Play it back for us.
Yeah.
That's pre-nitro, I guess, right? No, that's the one.
Oh, this is the last one still.
So Jay expertly navigated into this one. This is the more medial, and I think that's a great target for us there.
Yep.
How do you guys feel about it? I don't know that I would give additional nitro here. We've kind of already done it into this vessel.
So Leigh, what do you think about that little branch that's more proximal, higher up than where the microcatheter tip is? So if you guys just cycle that, it's going medial.
I'd pull back and include it.
Yeah, I think I would include that too. It looks like it's going.
This kind of medial branch right here?
Yep.
Yeah, the one right above where the tip of the microcatheter is.
It's embolized from more proximally,
we can puff back.
Right? Yeah.
So like a centimeter or two up.
I agree.
This is the Casadaban proximal technique?
Exactly. So your question earlier, Dan, flow reversal. I have not had the same success with flow reversal. It's actually one of the reasons that I'm a little bit more hesitant these days to give a lot of nitro because I've had that happen more than once. So I tend to come from the collateral vessel at that point. I'm at baseline searching for all genicular arteries in every case. So So that's what I tend to do. But yeah.
Are you guys going to give nitro here?
I wasn't going to give it. It's the same exact territory. Do you guys feel strongly about it?
I do not, but
no.
I think this looks great.
So
yeah,
exactly.
I agree.
Well, I think Cubby just established that he wouldn't, definitely.
The other thing that's interesting is it's correlating. This vessel's correlating more with that BB right above the patella.
Yeah.
Yes.
Cool.
There we go.
All right.
Nice.
Give like a 0.2 aliquot here and see how we do. Yes. When we're trying to get through and get the best images to look at our embolic, I've definitely found you're either between flushing all the contrast through and waiting for all the venous return to go away, or you can just be very judicious about it.
What's embolic?
Mm-hmm.
Do you guys find a dedicated suprapatellar branch on the cone beam out of curiosity?
I did not.
Okay.
If you did, would you treat it?
I would definitely be specific. That for me would be on a one-to-one basis.
Well, in this particular patient, though, with the presentation, that's a great point, Leigh.
Dan, while Jay's injecting this embolic, tell us a little bit about this Siemens Icono room and the fluoroscopy time and dose that you're getting with the fluoroscopy times that you typically see with a knee embolization as compared to what we were using previously.
Well, I'll put it this way. It's astronomically low. In full disclosure, knees aren't that hard on a machine. So in all honesty, what we're doing here with prostates to me is much more impressive than the knees themselves. Actually, we can tell you. Hey, Geraldo, can you tell us what was the radiation on the spin that we did, the CT? Because they're astronomically low, and we'll get you that information in just a second. But for us, to me, the test of a machine is prostates. It's small vessels. It's 45 degree angles in the pelvis on an American-sized adult.
Yeah.
And so and you can attest, I think, better than anybody on how well the machine is doing. The bang for the buck on that is really the best. Here, we're getting beautiful images. Don't get me wrong. That's less impressive to me, in full disclosure.
Yeah.
Now, is the bore size larger than a typical any of the older Siemens systems for
12.7?
It was?
12.7 for both spins.
Yeah. So both spins, remember I was saying the protocol has a non-con and then a contrast, 12.7 milligram.
Right?
Okay.
Both spins
That's
combined.
awesome.
So
That's really good.
it's anybody that says there's a radiation, they just don't understand the context of it. So here's our run now. I think this looks great.
Yeah.
And Jay, preempted, he gave us a beautiful reflux into the other one where we see that one's treated beautifully too.
That was intentional.
I agree.
It was totally intentional.
Yeah.
I think this looks great. What do you guys think?
Great.
I agree.
It looks like
wonderful.
that other branch that I was talking about before that's going a little bit more lateral on the screen is like a muscular branch or something.
That's what I assume. The cone beam
Definitely. Yeah.
That's what I assume. Yeah.
Well, it's good you preserved that one.
Yeah,
What's
it really
your-
came out beautifully.
Leigh, what's your cone beam protocol?
Out.
Yeah.
I'm going to go for...
We also do it from the SFA.
Okay.
Usually it's like
Can
3
this
for
one- can you,
35, 36, something like
we get
that.
the overlay a little stronger.
6-second spin.
Yeah, that's what I'm. And
Equal
then
this.
I tend to dilute my contrast to less than 50%. And most of our patients are awake or moderately sedated, right? So it kind of helps in the
Right.
movement and that kind of thing.
Watch this.
Same. We do the exact same.
Yeah, the contrast can be pretty painful for them.
Yep.
Absolutely.
Definitely. Yeah. We've been diluting it as well, just kind of continuing the theme. Legs aren't that hard for the machine. We started at 100, then 75, then 2/3. We've been progressively going down, and we could definitely go lower. It's such a small amount of radiation and contrast, et cetera. So it's really great for us.
So the wire that you guys are using with the 1.9 is still the 016 wire, is that right?
We used a 016.
I think that makes a big
You wanna load
difference
up the
when you use an
mics,
016 wire
Yeah.
versus an 014 wire.
Definitely prefer it.
Yeah.
I tend to use a 014. Maybe I'm bucking the trend a little bit.
Yeah, me
I
too.
love the
014
Asahi.
for me as well.
Yeah. But the 17
Wanna try
only
the
takes
Meister?
an 014. So at least on the Asahi side, I can't remember on the Merit Pursuit
Well,
side.
I mean, a 1.7 shouldn't.
Let's do the
shouldn't be able to-
1.7.
Great.
I mean, it's an amazing microcatheter,
Yeah.
but to be able to, I think to have the wire as close to the tip as possible gives you much more trackability over the wire. I think sometimes when you get a mismatch, as an example, if you use like an 014 with like a 2.8 or a 2.4, it doesn't
100%.
track. It doesn't
Yep.
track well
At all.
So you really have to
Yeah.
match the
Yeah.
wire with the size microcatheter.
And then actually, I
See if
use
I
a lot of the
can save
Asahi
on here.
Chikai wire, which I find still has a lot of torqueability. Not all 014 wires. I think some of the 014 wires you lose a little bit of torqueability.
Yeah.
But I have a lot of great torqueability with the Asahi 014 wire. So
So Dan, what vessel are you investigating now?
So we're going over the superior lateral. We're going to go in with the 1.7, the volute. This is just
not, no, I want this one. I want this one.
He wants this one. Jay wants a different one.
The dark green.
This is just our angle glide cath.
Okay.
Dark green is
Or
what
French?
I want. We were just
or French angle glide cath through the prelude here.
So
Nice.
Leigh, what are your favorite base catheters for this?
Yeah, I'll be honest, I don't use a base catheter. I like to keep my system small, so I'll just leave the micropuncture sheath in the SFA and then get the micro through that.
Cool.
So you're doing all your navigation through the
where's the wire?
microcatheter. Wow. Okay,
Yeah,
that's
and I
different.
find
And
it's
you're- and-
you can
and
navigate
I
into these
missed it. What
vessels
are you
just
using?
fine.
Over here,
I'm using
yeah.
like a
We'll use the
1.7
for
and
now,
a
and then we'll
Fathom
switch when we
14.
do.
It usually gets in the tiny little vessels just the way you need it to be.
Now,
So yeah, I
how
don't
long
use a
are your
base.
microcatheters? How long are you using the
Cool.
shorter ones? Like 110?
Let's go in the 1.7.
Yeah, the shorter ones help for
It's
sure.
Yeah. There's actually some interesting stuff in development that are,
we get the
that
overlay
are,
a little darker,
even
please?
shorter.
Yeah.
The overlay darker.
For pedal access.
Yeah, very
where you
difficult
can
to see.
have a very stiff back of the microcatheter, sort of functions like a base catheter, but then the front of
Let me
it
straighten you up.
is going to be
Yeah,
a lot
I agree.
softer,
I've
like
seen
a
some of
standard
those.
microcatheter.
I think where I struggle is the
Nice.
larger patients, larger SFA popliteal
Beautiful.
arteries. And I find sometimes I just need a little bit more backup and support. So I still tend to use a base. I use a 405 French C2, glide C2 usually personally, and then I do
Glide
exactly
C2. Love it.
what. Yeah, I tend to select with the glide catheter and then place my microcatheter and then back my C2 out of the origin is what I tend to do. But I think the future is probably what you're doing, Leigh, in keeping the access as small as we can.
So in terms of the anatomy, Dan, the way that I sort of would describe this is that the DGA and the superior medial have the same origin, or they're coming off together. It's what it looks like to me. And then on the lateral side, we have a very large superior lateral, and then a small. If you look at that 3D image that you guys put up on the left there, that you're sort of windowing up and down. I can't really point to it, but it looks to me like there is a small inferior lateral.
I think so.
there.
Yeah, I think so too.
Yeah.
Yeah, I think so too. All right. So Terry, you want
It's
to
a
come
great
around?
image there.
Yeah.
Nice overlay.
Yeah, we're kind of titrating it up and down for you guys. Pull that one out.
I mean, the images are amazing
Yeah.
on what
They're
we're seeing over
Great.
here.
Awesome.
I'm going
Agreed.
almost exclusively antegrade. Are you guys all going antegrade?
I like
Yeah.
antegrade.
I like
For the-
antegrade.
Lateral
too.
Yeah, I mean, for the most part, it's what we're doing.
I don't
You
like
know,
to go up
people
and
have
over
different
if I-
desires. A lot of people, I don't mind going pedal.
I stick the SFA. I don't stick the common femoral. So yeah. All right. So are you guys? Do you stick the common femoral or the SFA?
I will do both, depending on kind of what the anatomy looks like. If I'm going to have a much easier time with the SFA, that's fine too.
Yeah.
Maybe the ice pack would be super valuable here,
Yeah.
right? Because we're looking at a lot of non-target branches, and then I guess the joint is some of these sort of stringier little branches going south. Maybe nitro would help here. I don't know. What do you think?
Yes, I mean, this is a common situation. Even with ice pack, we're getting a lot of cutaneous branches. I think the strength here might be the 1.7. This is pretty common, I think, in lateral. You'll see these cutaneous, and then you have kind of a skinny branch coming down. We see this all the time. I'll be honest, I'm not too judicious. I care more about getting the good embo than I do some of the cutaneous branches. How do you guys feel about it?
Well, I think if you're using 200s and you're not using these really tiny particles, I don't think there's an issue. I think nitro and ice pack, nitro sometimes hurts you in a scenario like this, right?
Yep.
Because you could put nitro in,
Just
and
dilates
you
the
may actually
cutaneous
dilate
branches.
the cutaneous branches.
Agreed.
Yeah, for sure.
Lee's earlier point: if that is a single feeder and you can sneak the 1.7 down into it.
No, I
100%.
think we have multiple feeders here.
Yeah. Okay. All right.
Yeah.
Because there's that other one that's sweeping around.
Yeah. Good point.
You see it's going all the way
Yeah,
around
no,
there.
definitely. I think a couple of obliquities, and
Yeah.
as silly as it sounds, the controls on the II, I don't know if you guys can see me pushing the buttons on the actual the flat panel detector itself. I find that incredibly helpful.
Sure.
Can we go back
Go
to
ahead.
access? How are you guys closing?
I was going to ask the same question, Leigh.
Yeah. I was trying to get there too.
Yeah.
I use AngioSeal
Okay.
for groin. That's what I do.
Dan.
Even in the SFA?
Okay.
I do use it as
For
if
SFA
necessary.
pressure. It depends where I'm at. If I'm up and over, then usually I'm going to be going up to a 6 French. Let's go with let's go with the Fathom. I'll use an angioceal on the way out. If I'm antegrade SFA, remember this is a 4 French prelude, so we're under 2 millimeters OD here, under 2 millimeters. So I think pressure is totally fine.
Okay.
Yeah.
And are you heparinizing these patients?
Yeah, I give heparin on access from the groin. When I'm going pedal, I'll actually give our radial cocktail. I don't know. What do you guys do pedal?
I've done it once. Couldn't get in the vessel antegrade, so went pedal.
Which vessel was it?
Gotcha.
Was it the DGA? Sometimes is harder pedal though.
Yeah, that's
Right?
the problem.
Can't remember.
Unless you have a base catheter or something to kind of give you a little bit more of an angle. So yeah, I tend to go antegrade SFA as well, but I think pedal is very relevant, especially in larger patients where you don't want to go antegrade. I think pedal may be very relevant there.
Yeah. We'll poke around here a little bit. Like I said, when I've encountered these situations, I've been fine with a more proximal embolic. We can definitely give nitro a little bit. Can we get the 014 tester actually? That would be great. But how do you guys feel about it?
About embolizing from here?
More proximally. It's kind of saying we have a more classic gull wing appearance here. And like I said, sometimes at the apex, I'll go from here. But go ahead, Cubby. I cut you off.
No, you're good. I mean, I think I would ice packs and I would probably treat from here.
One of the things that I found, Dan, and you guys may feel the same way, is if you start probing these little tiny branches, you might end up spasming them
100%.
anyway.
Yeah.
And so that's going to affect how much embolic you're going to get into the target branches. So I would feel comfortable with, especially with 200s embolizing from here with some ice packs. Yeah.
Agreed.
Yeah, I agree. Ice packs.
I didn't realize you guys are giving heparin with groin access. I don't give any heparin except for the heparinized flush. But can we talk a little bit about that if you guys are comfortable talking about it?
Yeah, I mean, I'll give like a 3,000 depending on the patient, 3,000 IV heparin. It's a single dose, a bolus when we go.
Probably.
Are you guys doing any heparin with your access?
Access site hematoma with heparin or no?
No, absolutely not. I mean, by the time we're done, even when we're not, talking about all the steps, it should be out. I haven't had a single issue at any higher rate. Otherwise, are you guys doing that?
I'm not.
You said Cubby, you're not.
I'm not either. I think it's totally relevant if you're sticking the foot, but I don't do it for CFA or SFA access. Are you just trying to prevent thrombosis of the geniculars?
No. I mean, anytime I'm accessing, I'm gonna want to give a little bit of a bolus here, and then when we're in the geniculars and we're static, we're doing the cone beams. It might be a remnant of when we were starting off and we were taking a little bit more time. But yeah, it's just a little bolus that we give. To your point, I'm not doing it with groin like a GI bleed or something. I mean, for other reasons, obviously.
Definitely not arguing against it or arguing to not give it. I'm just curious. So yeah, it's great.
Yeah, definitely, man.
So you guys are going to use the same size particles here?
Yeah. We're gonna go with the 200 hydropearls. Yeah, I mean, it's a nice example here where we have these smaller downgoing vessels. And like I said, it's a pretty common occurrence, I think, of getting these single.
I can see the inferior too.
Yeah.
Yeah.
If you look at the bottom of the screen on the 3D, I can see the inferior really well.
Yeah.
It actually looks bigger than it did on the angio, in that view at least.
Yeah.
This is also great because you can take these images and immediately find the angle that you need to cannulate it. Great. Which a lot of times with these genicular arteries, you're looking at it on FOSS and you're probing for a few minutes and you're not even close to the artery origin.
Yeah. 100%. I mean, and the other issue that you'll commonly see, and I'm sure you guys have encountered this, is that you'll have on a lot of them, and it's usually the same patient, you'll see it 3 times, but you'll see a little like osteostenosis that'll really give you a hard time trying to get in.
Yeah. That's the other reason, to Leigh's earlier point, where I tend to struggle a little bit with the microcatheter only technique, but
we give a little bit of nitro here.
My patient population is a little bit different than your patient population, Leigh, I think. So.
Yeah.
Yeah.
Lucky in Colorado, it's like the lowest BMI state.
Is it? Are you guys are really outdoorsy?
The highest. So you guys are.
Highest, exactly.
We're sort of in the middle.
I think that was really the express purpose of why we invited both of you guys. We had nobody from Hollywood.
I give you credit for doing antegrade on your patients.
I think your point is valid, though. If I have a lot of tissue, I don't hesitate to close the antegrade access if I need to, but I do prefer to hold. Now that gets into, should we be going sheathless at some point? I find that I just lose obviously a lot of torqueability in the base catheter, so I still tend to put a 4 or a 5 slender in personally.
Yeah, I mean, I just enjoy having it's such a small diameter that I think it's kind of the way to go instead of going in and out. I have no real basis for saying that's going to be better or not.
That's a beautiful picture there, guys.
Yeah, it is, right. If we look down the kind of near the joint space line there, I think we got a lot more out of it, and I don't think it really changed to anything too dramatically on the cutaneous branches that we see here. Can I get the 0.6 fathom?
0.6 fathom, yeah.
So with regards to patient selection, can you guys talk a little bit about when you're saying KL2, KL3, KL4? Actually, can I get an 0.14 fathom? When we're getting those patients, an orthopedic patient is like, oh, this is going to be great. And then you see them. Talk to me about the severity of the osteoarthritis that you're going to see, and when you're going to say, you know what, I don't think this is a great candidate, or maybe you don't have that cutoff, or what you do in those situations. I think a lot of people watching would be interested in that.
Great question. So in the past, I was doing everyone from KL grade 1 to 4, even the severe cases. But I think, newer literature is showing that you just don't get as good as response in that KL4 group anymore. And so I will still treat them, but I'll have a long conversation with them about outcomes and expected outcomes. Just let them know it may not last as long. I mean, it could, but it may not last nearly as long as we're hoping.
Should we talk about nerve ablation?
Yeah, that's exactly where I was going. I mean, Leigh, you're spot on. That's exactly what I say. And then I have a very low threshold to convert to GNA. And we're actually using primarily cryo these days, although there's a tremendous amount of literature for RF as well. There's great RF systems. But that's where I flip. Probably those KL4 patients after an honest conversation. Also some of the post-TKA patients as well. But to your point, we're still learning. I think who is the best candidate, right?
Yeah.
Sometimes it's better to be lucky than good, right, Jay?
Yeah, no, that's really good.
Oh, nice.
I don't know what you're talking about.
So
the problem with nerve ablations is that they don't last that long. You find these patients coming back after a year and they're already in pain again, and you have to repeat it every year. So I think if a GAE works, it's more preventative, it's more long term. That would be my first preference for patients.
Yeah, that's exactly the conversation that I have with them. That's a great point. And also, I think some of the very, like a morbidly obese patient, that may be a patient that I decide to do GNA first, and if it doesn't work or they don't get the relief that I expect, then I may convert to GAE, something like that.
You want to try to go over yourself here? I'll hold it.
Exactly.
The microcatheter. Give yourself back attention, yeah.
Yeah, post-TKA is an interesting point.
More wire.
I've been doing GAE for those patients, and a lot of the times their symptoms are swelling, or like pressure in the knee. And I feel like a GAE really helps in that post-TKA population. And if it doesn't do the job fully, then you always have a nerve ablation as another option.
Great point. Are you using the same size particles post-TKA?
No, I go bigger, kind of like that hemarthrosis population. Those vessels are a little bit larger to begin with.
Yeah.
Oh yeah, tell us about that. So I was going to say, if you're going to a 400 or a 3 to 5 for that.
Probably 3 to 5.
Yeah,
for hemarthrosis. Yeah.
Post TKA.
So that's the other thing that I wanted to mention. The post TKA patients with the joint hardware, the radiation dose can get very high in those cases, and it's also really challenging, I think, to find those arteries. And so I think, Dan, in your experience with the 3Ds and the cone beams. With the knee hardware patients, what have you found? Anything interesting?
So I think the overlay is going to be clutch for that sort of thing. Yeah. You really get our protocols to a place where we can really get it with minimal streak, and then not have to do the crazy obliquities that you have to do for the hardware, because it's really a pain. I mean, there's no getting around it. Sometimes they're more straightforward, but a lot of these are just a pain.
I agree. They can be a huge pain.
Yeah. And so in terms of like KL4, I have a similar conversation, which is essentially that I'll talk to patients about, if you really have a lot of angulation, a lot of different pathologies, huge osteophytes, and say, look, this really isn't intended for you. almost every single patient that comes in the room, I'm going to have a conversation with them in terms of, this is between, very conservative therapies, anti-inflammatory medication, et cetera, and a knee replacement. And so when we get that, and I'm looking at X-ray, that context makes sense for them. So I've had people that, sure, they have horrible cardiac comorbidities. They're not going to be a candidate. And they're saying, I get it. Can you please try? And in those patients, I have a very honest conversation with them. And I say, look, this isn't dangerous. Nothing, your leg's not going to fall off. And some folks have actually had surprising results. And some people said, yeah, I didn't get too much out of it, but you told me. So, I get it. So that's kind of the conversation that I'm having with folks.
Oh,
Look at that.
it goes going up and around, not straight.
Yeah.
Yeah,
I think I'm just going to give embolic from here. I think this is great. We're really seeing the blush there.
Yep.
How do you guys feel about that?
Yeah, I think that's a great idea.
Gave nitro or didn't give nitro? Didn't give nitro,
the
right?
one that's curling around, you want to be behind it a little bit more.
Oh, we gave nitro. Yeah. I think it kind of changed the
okay.
flow dynamics. Yeah.
What kind of ice packs are you guys using?
Yeah, just a tiny bit, like a very minimal amount.
We actually have just
Right there.
actual ice.
Yeah, that's good.
In a
We're
bag.
putting it ice in a bag.
Like it's an ice. You should do the sports medicine ice bath. Just dunk the whole knee.
We could do that as well.
You can also use knee braces that you put in the freezer.
That's a great idea,
Yeah,
actually.
you can wrap the whole
That's a
knee.
great idea.
Yeah.
This is good stuff. That's a good idea.
Well, I use them on myself. That's how I know.
Well, that
My knee hurts when I wake up in the morning too. Don't worry. Yeah. Lee, when you go pedal,
Hey, I got a treatment for you guys.
Yeah.
Lee, when you go pedal, it's just micropuncture sheath and microcatheter and wire. Do you ever put a base catheter from the foot?
No.
I think the answer is going to be no. If you don't put it in from the groin, why would you put it in
Well,
from the foot?
I'm just curious. Yeah. For the sake of discussion, what about you, Dan and Jay?
I'm sorry, I missed the question. I'm looking at this really nice blush I'm getting with the embolic on the condyle here. How do you guys feel about that?
Yeah. I see
Yeah.
that.
What was the question? I
Dan,
apologize.
Dan, the question was, do you use a sheath in the pedal
Sheath and base catheter.
and base catheter?
I think for me,
So the setup is very similar to what we have here.
Okay.
That's great. I'm really happy with that.
Are you guys going
we've
to check
all those
out that
cutaneous
inferior on that side? I think as the last vessel.
Yeah, we're
potentially?
definitely going to go to the inferiors for sure. Yeah, so I'm doing a very, very similar access that I do here where I have the 4 French prelude. I'm getting access in there. I give a cocktail. One thing that's actually nice, have you guys used the mini rim? It's a nice little U shape, essentially. Mary catheter.
Okay.
It's a Mary catheter. And basically, it's we can actually hold it up maybe. Let's open that guy up. Some of these are difficult when you're going up and over. If you have like the gull-wing appearance, and then on top of that, you have that osteostenosis, which can be a huge pain. We can kind of show you it's really nice. It hooks a superior medial really nicely.
Nice.
That's a 4 French?
Yeah.
That's awesome. Okay.
So if I'll usually just start off with an angled. I'm not doing anything crazy. But essentially what I'm going to do.
Is that 65 or is that longer?
No, this is longer.
It's much longer than you need. I think it was designed short, but it's not too much of an issue. I mean, we have it here on the screen. If you
like
want to see
2
it.
of my arms.
I thought you were going to call that a mini fishhook, personally, but
Yeah, that got
I mean, we can. That's
it
fine.
got discontinued. Oh, my bad. Okay.
You think your namesake catheter?
So you put a 4 French prelude in the foot, and then put a base catheter, and then a
Correct.
micro through that, and you stick PT or AT?
That's correct. I can do either. Usually I'll do AT because in case, I mean, it depends. If somebody very clearly has lateral pain, then that's what I'm going to go after. Yeah, then I don't want to make my life any more complicated than it has to be.
Sure.
For obvious reasons. But otherwise, I'll stick AT. If not, if I don't think I'm going there. Are you guys checking anterior tibial recurrent on every single patient?
No, I was looking at
also, by the
on
way,
image. I didn't see that a big recurrent. I mean, there is one, I think, but it's not that big. Yeah, I was just looking at that inferior lateral, which I think I see that on the 3D, right where your catheter is.
Oh yeah, definitely. So we have that classic kind of hook around the joint space there, and then we have this inferior medial, the kind of J shape going down. It's right over here. So I mean, it gets into another conversation about what is your pattern of embolization? Are you going after absolutely everything?
I do. I check everything, but that's me. But that's
that one.
again, that's where the cone beam really guides you, in terms of what you need to go after. But I tend to check everything, and again, with resorbables, I will have a very low threshold to embolize everything as well. Leigh, what about you?
Yeah, my goal is at least 3 genicular
Go to the one
arteries in
now.
every case. I
Yep.
I think there's a paper that shows that if you do at least 3, you get a better outcome. So that's my goal, at least 3. I've honestly moved away from the anterior tibial recurrent. First of all, it's really hard to get into. Second of all, I think just its close proximity to that peroneal nerve makes me very nervous. When you do GNA, we don't go for that location because of that reason for foot drop, and so it makes me nervous to be in that area in general. So I stay away from that one.
Yeah, I think I'm kind of on board with the same thing. It's very rare that I'll do less than 2 or 3 vessels, generally speaking. I am a little bit partial, I'll be honest, because you can see the BB marker was on the medial side here. I might be, if I really see something very diminutive on the lateral side, I may not necessarily jump at that thing if there's a really bad osteostenosis, but it's rare. I'm going to investigate just about anything. If I see a blush, because we know about the anastomoses, so I don't think anybody out there can say, no, you get the 3 vessels and then you're done. You saw blush, you didn't see blush. This is the result. I mean, we already said it's very tough to make that call intra-procedurally and then say, oh, this person is going to have a great result because I saw a vascular blush and this is a great technical result. So I think that's my thought process when I'm saying I'm going to look at just about everything, and I'm going to, with certain biases for where they are complaining of the pain, I'm going to take out blush where I see it. If you guys are being more aggressive in that sense, have you found differences in efficacy, differences in the amounts of post-procedural pain, or what's your experience been with more vessels versus less vessels? Because some people will definitely say, oh yeah, the patients where I'm doing 4 vessels, tons of embolic, they're having more pain post-procedurally. What's your experience been like with those patients?
It's a good point. It's a trade-off for sure. Those are the patients you're probably going to give a little bit more NSAIDs. You can even consider steroid pack afterwards because they're probably going to have a little bit more inflammation from the procedure itself. Yeah, it's a trade-off.
Yeah.
It's a good point.
Are you giving anything intra-procedurally? We usually give Toradol, so that's what I was actually going to do shortly. What are you guys doing, if anything?
I give Toradol.
I do give Toradol as well.
Yeah.
And what about?
As long as the kidney
Such a
functions
great
good.
drug.
Yeah.
Of course. So actually, let's give 30 of Toradol.
But-
And in terms of periprocedural, anything else? You said a Medrol dose pack?
I do.
Do you do that standardly? I tend to reserve it if they're having pain, but do you do that standard on everybody, or is that when are you giving that?
Yeah, it's a standard for us, just like a TACE. It's built in our protocols for.
Okay, got it. Say again.
I was just commenting on Jay's expert technique here, getting into that vessel.
Beautiful.
Spectacular.
So this is the 1.7, Jay? Is that what you're using?
This is the 1.9 actually.
1.9.
It went right into
So
this.
I mean, I
tiny
can't
little
even
vessel.
tell on the fluoro image, but they both perform
definitely not.
similarly.
Yeah.
That's great. I mean, getting a wire like that into that tiny branch is not always so easy to do.
Yeah.
Wow, look at that.
Yeah.
No, for sure. So we're gonna do a run
Especially,
here.
I always think that the hardest catheterizations are when you have a really small vessel coming off at a right angle from a large vessel, and the popliteal artery SFA
Beautiful.
is a great example of that. And so,
Looks good.
if the angle is nice and shallow, it can be easier. But this would be a very challenging branch, I think, from the pedal. Don't you think?
Without a base catheter specifically, I think if you had that.
Without it, it would be
Yeah.
tough to do. Yeah.
Yeah.
I think that the hook would really be helpful for something like that.
Yeah. Yep.
So this is a pretty classic appearance for the inferior medial where we're getting these angles. I'm going to give nitro here. Covey, don't cringe as I do it. Okay.
Yeah.
And Leigh, this is pretty classic appearance wise. Are you also going distal? Do you go past the hook on the inferior medials, or do you go a little bit more? You're going past the hook on the inferior medials. Wow.
I do. I want to get past all those little collateral branches that are probably cutaneous branches.
We're going to do a run here.
Like. Yeah.
Yeah.
So Leigh, you
Covey, what about you? Where are you? Where in a case like this, relative, let's say, to where my catheter is right now?
Plus minus. I think to Leigh's point, if you can get a little bit more distal easily, then I'll take it for sure. If I can't, then I'm not going to push it and destroy that vessel trying to get there. You know what I mean?
I would give nitro and go. What do you think?
I'll be honest. I'm usually
I probably would not give nitro, but that's okay.
Well, he wouldn't give nitro. I think we've established that. For me, from my standpoint, we've had great efficacy with these. So by the way, that's just the catheter. This is the 1.9, not the 1.7. Went right by.
That's beautiful.
My bias, I have to be honest, is the efficacy of it. And there's a little bit of that anastomosis right there. You see that to your point, Covey, there's your flash right there. Beautiful.
Right there.
And that I think, it's one of those things. Yeah, you see it as I go a little higher, and it flashes up to where we embolized before DGA and came back.
Yep.
So I'm going to embolize from here. How do you guys feel about that?
Yep.
Yeah.
Beautiful.
Yeah.
No cutaneous branches. I think it's perfect.
Yep. Agreed.
Yeah. There it is. You see it right there? Yeah.
Yep. So Leigh, you're giving Toradol in the procedure and then a Medrol dose pack at the end of the procedure to go home with. You give anything else?
Not always the Medrol dose pack. It really depends on, how hard we went during the procedure. And I'll talk to the patient about it as well. And then usually naproxen for 5 days after as well. How about you?
Yeah, I tend to do more ibuprofen, but I think naproxen's great. So.
And that's all you give?
Dan? That's what I tend to give. Yeah, and I'll see them post. I'll keep tabs on them closely, and then if I need to escalate and add a Medrol dose pack, then I'll do that. I think your point is very, very valid, and same with a lot of the liver patients as well, right? Even for if I'm super high dose rad seg, I kind of have that in the pocket, and I'll give that if needed. But that's what I tend to do. What about you, Dan?
So I basically tell them if they can take it to use whatever anti-inflammatory they're using. Almost every patient that comes to me, I'll give them a naproxen, Aleve, ibuprofen, Motrin regimen. I've found that people have all sorts of biases for over the counter. But in essence, it's going to be whatever any of that category of over-the-counter anti-inflammatory. We initially gave more of a Medrol dose pack, more steroids, and a couple people just didn't tolerate it, oddly, which we've done it in other procedures. And so I essentially stopped doing that for that reason. And patients have been doing great, to be honest with you.
So one thing I wanted to comment on, Dan, is as you're moving the equipment around up and down, your 3D roadmap is adjusting to your movements. Yeah. So are you 100%, not moving the table? You're not moving the table up and down, but you're moving the table side to side and the II back and forth. Is that right?
And rotating.
Yeah. So basically, because it's a very sophisticated program, it will lock into this location. I can move any way that I want to. It actually has, if you saw, we had 2 BB markers. It can self-adjust based on those points if there is movement. But I'll just do it live. I don't know if you can see this, but essentially, as I'm going around, it basically follows me around. Can you guys see the overlay here?
Yep.
Yeah.
Nice.
So it follows me around. There's no such thing as losing your roadmap. And it really allows you to open up the obliquities. The cone beam CT, the 37 thing we can talk about that the cone beam CT really helps with is showing you if there's a weird angle at the ostium, which will save you so much time. But it follows me around and kind of shows me. And you can titrate the branches. I mean, this from the prostates when we were working on it initially to see if you want to see more vascular blush on the overlay or not. So I'm going to show the last run here.
That looked really good. I think
so this is post-embo. How do you guys feel about this?
Yeah. I mean, the blush is essentially gone. All you're seeing is the anastomosis.
Yep.
Yeah. I think, we have really good antegrade first order, a little bit of second order there. I see no blush and we see beautiful anastomosis. I think this is great.
So I agree. In a case like this with somebody with medial knee pain, I would almost feel like we're done here. But I mean,
I think that's very reasonable.
Yeah.
But I for me personally, I would still check that inferior lateral, but I think that's very reasonable.
Yeah.
What about you?
I think in my case, definitely I would go and check it. Yeah. Leigh, you would?
No, I think this is a great endpoint. 3 vessels, that's what I would go for. If I had time, I would go for more.
Right?
Yeah.
Technically, it was 4.
But
DGA.
DGA.
The DGA
the 2 branches. Yeah.
So we essentially hit 4. The lateral, inferior lateral on that side is very small.
Yeah.
I'm not sure you're going to see it.
Yeah, I mean, I think there's a compelling argument here, definitely, given where the location is. Kind of, I was saying, my bias is to investigate all of the vasculature. I've been surprised before. I'll be perfectly honest. It's really that. As I've been doing that, I've been really surprised. And then also to Leigh's point, going out more distal, it didn't look like much. Can we get the wire? It didn't look like much. And then I went out there, gave him nitro, and then, wow, this is a blush. But I think, I think I'm a little bit more aggressive in that sense that we're investigating everything. A lot of people would have said, this is a great job. We're done here. This is where the patient had pain on the superior point and on the medial point. So I don't think we really have the data to say at this point, do we stop, do we not? It's definitely my bias to investigate more, though, for sure.
And I still, I know we talked about this earlier, but I think in the era of resorbables, it just, I think the risk benefit ratio is optimized towards benefit with resorbables, right? So, what's going to be the downside in effectively a whole knee embolization in that scenario, and limiting the potential for unmasking lateral knee pain or something along those lines, right? So.
No, it's a great point. I think what you're doing and where it's going and looking at the anastomosis. Yeah.
I think the mistake that you can't make is non-selective run, no blush, we're done. That's the mistake that you can't make, right? I think we've already said it multiple times, you have to investigate different vessels selectively.
Yeah, there's so many scenarios where you do an
you may not
angio.
see the blush unless you get into it.
Exactly. Yeah.
Exactly.
I mean, this is a great example of that. I think this procedure in particular. It happens in other vascular territories too, but this is a specific example where that's very relevant. Yeah.
I don't do a lot of selective cone beams. Sounds like Leigh, you don't do either. What about you, Dan? Or Leigh, go ahead, please. I'm sorry. Yeah.
Selective cone beams from within the genicular vessels?
Yeah, I know people have talked about that and published on that. I tend not to do it, but yeah.
I don't know that I'd necessarily see an enormous amount of utility. Like I said, the way that we're able to do it and the radiation doses, I don't think that's unreasonable.
Agreed.
But I don't know that I necessarily see the utility. What do you think would be of the greatest benefit of doing a selective cone beam in that situation?
I mean, I guess if you just weren't sure, or maybe if you didn't get a non-selective and then you were just getting individual selectives, maybe that's one avenue. Or if you just weren't sure where those collateral branches were going and you just were trying to be extra careful, maybe.
Yeah.
I agree with your sense. I tend to not find a lot of utility in it. I feel like from that non-selective cone beam, I can figure out what I need to understand and then go after individual.
Yeah, I mean, I think we get the information that we need from what we have. Yeah. I mean, I'll be honest. If there was a compelling reason, I think we definitely could.
Very reasonable to do.
But I think kind of to what Aaron was saying, we know that this is a small vessel, and we not just on the angio, we know from the cone beam itself that this is not really a major feeder for her.
Yeah.
And so that's really
a tough one. It's a
small vessel.
It's small, but it looks bigger because we're zoomed in. But I think it's got a little weird angulation at the origin.
This needs the expert fingers of the real Dr. J.
Yeah.
Does it? Oof.
Nah. Nothing.
I think what we should do is let me mess around for just a second. And then, we'll kind of take it from there. What do you think going forward? Do you guys see a radical change in anything that you're doing in terms of? Actually, while I talk about this, we need the real Dr. J to get in here.
Let's see what happens here.
What do you think going forward that we're going to?
That's it.
Yeah.
The real Dr. J. So to answer your question,
this is where, go ahead.
Yeah. I think unanswered questions. Let me frame it that way. Patient selection, right? Which patients are the non-responders that we're still trying to figure that out and iron that out. What is the utility of that preoperative MRI and synovitis scoring? I think that's another big question in my head. The other thing I was going to ask you guys, I want to discuss repeat GAE quickly, but we don't have to put that in this conversation. Leigh, what about you? Unanswered questions.
Yeah, I totally agree. And I would add embolic choice.
Great point. Yeah.
Yeah.
I fully recognize we're probably never going to have a comparative study of embolics or
it won't go any further. The wire.
Probably anything significant.
Can you play with the wire?
But,
I'm gonna hold this here.
That's a great point. So
you might be able to just do an angio from there and see what that looks like.
Just all get kicked out.
Yeah.
Cavi, I totally agree.
I'm going to see if I can take the opportunity to kind of mess up Jay's selection here. That's really what I'm going for.
Let's just puff here maybe and see what's going on.
Yeah.
Might be able to puff and push.
I'll revise my
there's definitely like a weird little hook.
There's like a little angle in the vessel it's probably bumping up against the wall.
Yeah,
mean,
there's like a little I think there's a little osteostenosis here is the issue.
Yeah. You could probably embolize
Do
from
you
here
have a
if
little puff here?
necessary.
Yeah,
I
yeah,
don't
yeah.
think there's a lot of
Give it a little
proximal
puff.
All right,
branches
so
off
let's
of this
hold the
thing.
micro.
I don't
I'm
think
gonna
so
put this
either.
out.
Let's see where it is though. Leigh, I'm going to revise
Yeah, we'll
my
give it a little
statement. I think
puff.
we'll
We'll see where
probably
we're at.
have a permanent versus resorbable trial at some point. I don't know if we're going to have resorbable versus resorbable data, significant data, but I don't know. Tell me how you feel.
A little bit of air.
Yeah, I totally agree.
Yeah.
But I
Do a
think
little
what we
puff here and
found
see where
is
we're at.
that GAE works no matter what embolic you use, which is great. I think it doesn't matter what embolic you're using. I think that's really the fine tuning aspect of making sure
You want to
you
try that
have low
Meister wire, see if
risks
it goes
and
around the
it's
turn?
Sure.
getting all the, efficacy that you can out of the procedure.
Yeah,
one more.
absolutely. Great point.
There is a little turn here that's a little annoying.
Yeah.
So I'm going to try the Meister wire to get a little around that.
So I'm going to just talk a little about this wire because I love this wire for
Meister? I love it as well.
for prostate embolization. The nice thing about this, it's 016, but it has the tip is a lot softer than the Fathom.
Yeah.
It's also much
You need a
easier to
wicked
shape
curve
the
here,
tip
right?
to a very sharp angle. And so for something like this, where you're trying to make a very quick turn, but then you don't need a lot of support to finish the job, this wire tends to work really well in scenarios like this. So, my two favorite wires in general, just across the board, are going to be the Fathom 16 and the Meister 16. I don't personally use 014 if I can avoid it. I know you like them, and we've talked about that. But let's just see how this works. The tip of the wire. What shape did you make, Dan, before you put that in?
So I didn't do your patented question mark.
For this, you don't necessarily need a question mark because that's not the
Wait,
anatomy.
did you say
here.
question mark or fish mark?
Well, question mark.
Oh, sorry. Okay. All right. So the 5 wires I carry in my lab, I have a Fathom 14, Fathom 16.
Came out.
Yeah.
I use a lot of the run through, the Truma run through. I like that wire as well. It's an 014.
Yeah.
And then I have the 2 Asahi wires, the Chikai, which is an 014, and the Meister, which is an 016. And those are the kind of 6 that I have, 5 wires that I have available to me. But again, I a lot of liver stuff as well, and really don't use an 018 wire at all anymore, actually, in my practice. Leigh, what about you?
Yeah, I like the
damn
Fathom
it.
14 for
tough
most
turn.
of my work here.
Yeah.
I have used the Meister. I think that works well as well.
Meister's for somebody that uses an 014 wire primarily. The Meister's probably a great option because it feels almost like an 014, but it has a bit more support.
It's kicking out. I don't. Maybe this
And
isn't the
the
wire.
tip
to go.
is a
I'm
lot
gonna grab
easier to shape.
014 Fathom.
Yeah. Let's do that one.
The nice thing about Fathoms, in particular the 16, is it's very reshapeable.
Yep.
But that means that it also doesn't hold its shape very well.
Yeah.
So there's a
100%. I mean, it
trade-off.
changes, but you can use it a lot. I think the other, to your point, I think the issue with the Fathom sometimes is you'll get them a little bit into a vessel, and you won't necessarily have the body to kind of track over it, and that's why I kind of prefer the 016s. I don't know what your experience and why you like the 016s more, Aaron.
Well, I with its sharp angulation and I'm just thinking about
there's 014
prostate
Fathom.
mainly, and I think that having the support of an 016 is valuable.
Yeah.
For this, it's probably not as relevant. I think in the knee, it's probably not as relevant because the vessels are longer and straighter. But when you have lots of different angulations, I think it can be a little bit more challenging with the 014s.
Well, and in that situation in particular, I will primarily use the long taper on the Fathom 16, the 20 centimeter taper.
Oh, interesting.
The 10 centimeter taper I find to be
Really?
a little bit stiffer in the liver. I do. In the liver, I'll tend to start with the 20 centimeter tip, and then I'll move to the 10 centimeter tip if I need more support. But I agree. I think in the knee, I don't know that it matters that much. Leigh, what about you?
Yeah, like I said, Fathom 14. I'll sometimes if I can't get in, I'll use a Synchro Soft. You guys ever use that one?
Yeah,
Great wire.
Good wire too.
It's a great wire.
And the
I always get
Aristotle,
some
another great
evil
wire.
eyes with the expense. That's why I try not to use that one. But
Of the
Well,
Synchro?
the Synchro
I
14,
know.
not the soft, but the Synchro 14 is exactly the same as the Fathom 14.
Exactly the
price
Fathom
standpoint?
14,
Yeah.
From the wire.
oh, the wire standpoint.
The price is different, but
price,
Yeah.
but it's the same wire. The Synchro soft is a slightly
agree.
different wire, obviously.
Yep.
So that you're not going to get
Yep.
in the
It's
peripheral
neuro
version.
pricing.
Yeah.
You're gonna hold it there.
Narrow price thing,
Take
yeah.
The wire from there.
All right. I mean, to be honest with you, I think we've covered a lot of ground. I don't know how we're doing on time.
We're getting close. We're at about an hour and a half.
You want to leave it there?
So
and I'll take the wire.
We can keep
If you-
plugging away here.
if you want to make any closing remarks, Dan, on this case, honestly, the imaging here and the
beautiful.
quality of this case and the quality of your guys' technique here is really stellar. And so thank you for that. But if you have any closing remarks, that would be great.
Yeah, absolutely. I mean, I think we really demonstrate kind of what we're doing. We'll keep going here. We might even, do a run in the tibial recurrent, but I think the basic concepts, our approach to it, is really pretty clear here. For anybody watching or anybody who's online, like I said, post what you want us to do, and we can definitely try to accommodate that and kind of do a series going forward. Again, I want to thank everybody. I'm really proud that we were able to get this room up and running. I think we're going to do some great stuff over here. The Siemens machine here has been incredible, and we're going to continue to show that off. And thanks so much to Asahi for letting us show these catheters. So do you guys have any closing thoughts, any closing commentary as Jay's working away here?
I'll just say this is an excellent case. New procedure and so many different techniques, on how to do the same thing. But I think this is great that we're talking about it and we're getting out there and comparing how we do things. But yeah, this is an excellent case. You guys did a remarkable job. I think she'll have a great response.
Yeah, I echo that completely. And then just a quick note on that cone beam. I know I've said it multiple times already, but whether it's the liver or somewhere in the peripheral body, I find I always learn something off of a cone beam, right? There's always an unanswered question. It's always helpful. I know not everybody can get a cone beam in every setting like the OBL settings, but I think especially if you're starting early in practice or early with GAE, it's a really, really helpful tool.
Yeah, I mean, I think we've definitely demonstrated the utility, and maybe on the next one we'll show off any new things that we can do with it. All right, so thanks a lot for joining us, and we'll catch you on the next one.
Thanks, guys. Really great case.
Great case, guys.
Excellent.